Good afternoon, everyone. My name is Jessica Pirro, and I'm the CEO at Crisis Services. And I want to thank you so much for joining us today for this Facebook Live event that we're hosting to talk about emergency mental health response services here in Erie County. I first want to introduce our panel of crisis response experts that are joining me today from Crisis Services. We have Robyn Wiktorski-Reynolds, who's our Clinical Operations Officer, joining us. We have Jessica Stuewe, who is our Crisis Intervention Team Training Coordinator. Tracie Bussi, who is the Director of our Emergency Mental Health Response Services, and Jacqueline Kimbrough, who is the Supervisor of our CIT Crisis Case Management Program. So we wanted to bring you a panel of experts here from Crisis Services that really have different roles and responsibilities of responding to emergency mental health services here in our community. And in light of the various situations we have been watching unfold, not only nationally, but here locally and regionally in response to mental health calls, we thought that this is a timely conversation to really help provide awareness, education, and also how to access the services of Crisis Services as the 24-hour crisis center for our community. We have a vested interest in the safety and well-being of our community, especially individuals in crisis. So we hope that today's conversation really helps to provide some good education, awareness, and maybe some help. So when you're faced with a situation, you know what to expect when you do contact Crisis Services and have a response that comes in from our crisis first responders. So before we jump into our discussion, I just do want to address that as part of our program, we're going to be touching first on the different aspects of the services that I mentioned with our panel. And we also are going to do a Q&A component of questions that we've already received in monitoring kind of our social media and questions that we regularly get about our agency and our services. But we also will be monitoring your comments as you're viewing this program. And so please add your comments or questions in, and we'll do our best as we kind of wrap up our conversation to make sure that we're addressing those. And if we're not able to get to them, we'll definitely look at those and see how we might be able to do some follow-up social media posts and educational moments to help with that information. So again, thank you so much for joining us this afternoon. We really do believe this is a critical conversation at this moment. So I would like to actually start with Tracie Bussi, who is the Director of our Emergency Mental Health Response Services Department. And part of that department is our Emergency Mobile Outreach Program. So Tracie is going to talk to you about that program and what the services are provided through our team that is in that department.
I'm going to turn my mute on off here. Good afternoon. Thanks, Jessica. I'm really pleased to be able to share these services. Most of the services we're talking about today sit within the Emergency Mental Health Response Program that I oversee. So I'm really proud to be able to highlight some of them right now at this really crucial time in our community. So I'm going to talk first about mobile outreach. This is a long-standing program at Crisis Services. This program in itself is in its 40th year of service in the community. So we've been around the block here at this point. The role of mobile outreach is to provide emergency mental health evaluations to individuals that are at risk of psychiatric hospitalization. So for these teams to get involved, we're receiving calls. We'll talk a little bit about how that process comes in, but we're receiving calls for individuals that there must be some level of mental health crisis occurring at that point. So this can either look like some increase in existing mental health symptoms, or it can look like onset of new symptoms that are not familiar for that individual and that family. But these must be coupled with some level of danger to self or others. And that can look like suicidal thoughts or behavior. It can be behavior that is dangerous to other people around the individual. It could be an inability to adequately care for oneself. So any of these things, but these things must be as a result of their mental illness. So somebody that is acting dangerous to others, but it's not really a mental health issue, that really wouldn't be in our wheelhouse. But we're going to help people to assess that as they're calling in. It really is the combination of the mental health piece and the danger to self or others that will warrant us to be responding at that point. So unfortunately, this is a much needed and very in-demand service in our community. In 2019, this program opened over 4,500 cases that year, and an additional request for service somewhere in the area of 1,000 to 1,200 other requests that we were able to just resolve kind of telephonically or through referral and linkage. And nearly 2,000 mental health evaluations completed in the community in 2019. So big numbers in this program, very large need in the community. Oftentimes we're asked who can call, who can call into your service. Anyone can call in. The bulk of our referrals, more than half to 2/3, are coming either from family and friends, so somebody that maybe lives with or knows an individual in crisis, or service providers in the community. And service providers can include a mental health professional, maybe a counselor or a psychiatrist that's working with somebody. It can include a medical doctor. It can include other agencies such as Adult Protective Services, maybe. 15% of our referrals come from law enforcement. So they have encountered a situation where they need assistance and they are calling us out to respond. And we do provide very rapid response to police calls that are coming in. And the rest of those intakes, they're coming from anybody. So anyone can call. They can be, it could be a landlord, it can be an employer, it could be a stranger on the street that's come upon a situation that they feel that somebody needs some assistance. We will take that call and we will assist at that point. So typically when that call comes in, if you do call in, you will get our hotline counselor first in our crisis counseling program. They're going to ask a few questions, and once they are able to triage the call and realize that this sounds like a mobile outreach response, they're going to transfer that call over. And if someone's not available immediately and they have to take a message, that doesn't mean we're going to call you back in 3 days. That usually means within a few minutes to a half hour at the most. So it is a pretty rapid response. Once that call gets into mobile outreach, there's going to be a few more questions. If we determine that this looks like something we should be responding to, an intake will take place. And typically that doesn't take more than 10 minutes, sometimes 15, just to collect information, address, history, things like that, just so that we know what we're responding to and that we can set up the best plan, which would be the next step. Very often that next step is us going out into the community to see the individual. And those responses are pretty rapid. So a quarter of people are seeing a response is initiated within 30 minutes of the time of a call. Another 14% within about a 4-hour period, and a total of 83% of our responses are seen the same day. And that the remainder, it's usually just because of logistics. So our goal really is to see people very quickly at the time of the crisis and not to be scheduling things hours and days out. On all of our assessments, we do have mental health professionals. So these are licensed social workers and licensed mental health counselors. On all of our assessments, there's at least one. And these mental health professionals are also 945 designees for Erie County. So that means that they are able to enact an involuntary transport to a psychiatric emergency room if necessary. It's not the purpose of our program. We are a hospital diversion program. We're very good at diverting people away from the emergency room about 2/3 of the time. But if safety becomes an issue and we're not able to safely divert someone from the hospital, that designee has a responsibility to that individual in crisis, as well as to the community, to see that that person has further psychiatric evaluation, typically at CPEP. Another thing that people often ask us is around our use of police. You know, if I call you, are police going to show up at our door? We really are we work very independently of police until we need to bring the police in for safety reasons. So as we're assessing the situation, we need to be certain our staff are safe, and we need to be certain that the individual in crisis is safe as well too. In those cases, we will bring police along to escort that process, but it's done on a case-by-case basis, and it's not on all cases by any stretch. This program is 24 hours a day, 24/7, 365 days out of the year. So that includes overnight on Christmas. We have counselors available to take calls and to respond at those times. There is no wrong call. So our hotline counselors and our outreach counselors can assist in assessing the situation, determining next steps. And even if it's not something that we can provide, we can direct people. We do a lot of referral and linkage over to out into the community, even into other programs within the organization, and we'll do some collaboration with service providers out in the community at that point. I'm going to turn it back to you, Jessica, I think.
Thanks, Tracie. And I think we'll be touching a little bit more as we get into the Q&A too, just about the process. Because I think one of the things we want to hopefully achieve today is a lot of education, but also kind of demystifying what it looks like, and also our role independent from other emergency providers here in the community. So thank you for that summary. Next, we're going to hand it over to Jessica Stuewe. Jessica is our Crisis Intervention Team Training Coordinator. So when you've probably been seeing some of these reports around CIT officers. So that's what the Crisis Intervention team represents, is CIT. And Jessica is our trainer and trains law enforcement regularly. So she's going to talk about our training, what that looks like here in Erie County, and some of the kind of the types of training that is done, what's discussed with officers when we go through that process. So Jessica.
Yeah, thanks, Jessica. So my name is Jessica, and I am the CIT Training Coordinator. Crisis Services is the sole provider of this training for law enforcement in Erie County. And it's delivered through us because we are able to work and collaborate with all of the outside providers, as well as all of the different law enforcement agencies within Erie County. We've trained a total of 617 officers since we started this in 2013, over 28 different departments. And specifically in Buffalo, we have 136 law enforcement trained in Buffalo at the moment. And hopefully we'll be getting more of that soon. Our training consists of 32 hours of classroom training, and then 8 hours of a ride along with mobile outreach. They can actually get out into the field and see what mobile outreach does, and help or see what they do in a crisis to learn from them hands-on. And our classroom hours, we go over emotional distress, trauma-informed care, empathy and communication, suicide prevention and assessment, what crisis services does, what a 941 is, a 945 is, which is taking people to hospital involuntarily. Also intro to mental health services and what other mental health services are around for officers. And we also partner with people in the community to bring other presentations. For example, ECMC comes and does an excited delirium presentation, as well as a mental illness presentation. We have deaf access services come in. The VA helps us, the Alzheimer's Association, community services for everyone, talks about developmental disabilities. NAMI comes in and talks to the officers, and also the law enforcement helpline comes in and does officer wellness for the officers and taking care of the officers. The rest of the 32 hours is spent on hands-on scenario training that we do in the classroom, so the officers can put all these skills to the test, and we can talk through the situations before they actually go out and use these skills. Our training is done. The goal of the training is to reduce the use of force and unnecessary transports to ECMC, along with help officers recognize mental illness and what are the next steps to do next, and where can they refer people to. So the collaboration, our training is done with collaboration with all of those outside presenters, as well as training officer trainers from different departments. We meet with those officer trainers on a regular basis to evaluate what's going on with the training, what are our best practices, and make sure we're meeting the needs of local law enforcement officers. And our training has kind of evolved over the years as well. So, and it'll probably keep evolving in the future as things change. While we have a hold on training right now because of COVID, because COVID put a hold on everything in life, we have been putting out mini mental health trainings for all of the CIT departments in the area. And they're just little videos every week to show kind of refresher and keep officers engaged in different mental health topics. And we've even gotten outside presenters like the Alzheimer's Association to come help us with those as well. And those will be up, and law enforcement can look at those anytime they need a refresher on things too. And then going forward, we are planning obviously more trainings. Hopefully we can get a lot of officers trained in the upcoming year, now that things are a little more settled. And we've been our training dispatchers, but now we are going to be training them virtually. And we've created a digital dispatch training that we'll be rolling out soon to help dispatchers train on their downtime, or when they have time, instead of having them go to the full 8 hours in a row. So we'll also be getting more dispatchers on board with the CIT training. and hopefully we'll be getting more officers training soon. So that's pretty much what we do. Jessica, want to take back?
Great. Thanks, Jessica. I appreciate that. Yeah, I think one of the things I just want to highlight from what you said is really the collaborative training model that's done as part of the CIT curriculum. There's many CIT trainings that occur throughout the country. And I think when we came together in Erie County, we knew how critical it was to make sure that all resources were part of this training, not only the importance of responding to somebody in a mental health crisis, how to approach that, but what are the other partners that are available 24/7, or just other situations that might include with their mental health crisis. So I do want to applaud us here for that development, because it really has brought more understanding of how law enforcement can collaborate with the behavioral health system in those moments of crisis when they're responding, and really kind of guide people back into the mental health and behavioral health system after a case occurs. So thanks, Jessica, for sharing that information. So I'm going to hand it next over to Jackie Kimbrough. And Jackie, actually, she's been with us in various roles and capacities in the organization. She was a mobile outreach counselor that Tracie talked about, as well as Jessica was as well. But also now is supervising the crisis intervention team, the CIT crisis case management program. So I'm going to have Jackie talk a little bit about those services.
Hi, I'm Jackie Kimbrough, and I am the supervisor of the CIT team. One of the things with our crisis intervention team, we collaborate with the different police departments in Erie County, South Towns, North Towns, Buffalo. We get our referrals directly from the police department. So when an officer has interacted with an individual in the community where they've had to 941 that individual because of safety concerns, they've taken that individual directly to the hospital. We then get that direct referral where we follow up with that individual once they are out of the hospital. My team is made up of 3 case managers and 3 peer support specialists. We then contact that individual and just start to build a rapport with the individual to let them know, first of all, that there are case managers within their community and that we would like to be there to support them as they go through their individual issues regarding mental health and/or substance abuse. We want to let them know that our role is to keep them out of the hospital and to decrease their involvement with police. Our whole job is to try to give them that to support so that when they are linked properly with services within the community for their mental health or substance abuse needs, that it now becomes about their mental health and no longer about a criminal activity or having to interact with law enforcement for mental health needs. Once they do decide to work with us, we then call them, we touch base with their treatment providers. If they already have treatment providers, we provide that support with daily contact with them. We also have a program that branches off from our CIT department. It's entitled the Mission Vet program, where if individuals choose to, they can also work with us for up to a year, where we provide case management and peer support. We work with them on substance abuse. We have 3 really good peer specialists that have had their own life experiences and they've been able to navigate the system. And so they're very good at getting and talking to individuals about what those next steps might be. And then we can be there to support them by going to meetings or going to appointments or looking at situations in their lives that may not allow them to have their mental health as a priority. We can kind of sit down with them and try to figure out those things so that their mental health and their substance abuse can be a priority by eliminating some of those obstacles that they may face. Again, like I said, law enforcement is a big part of who we work with. They are able to point out those individuals within the communities that they may be seeing. Sometimes we get direct calls from law enforcement that they're voicing concerns about an individual in the community, and we're able to call that individual and try to make that connection so that individual can have that support that they need. And that is CIT.
Great. Thank you, Jackie. And I know we'll be touching on all of the pieces in some form or fashion, I know with questions that we're going to be getting to here in just a second. So, but I do want to thank the three of you for lending your expertise as part of this discussion today, and the understanding that day in and day out here at Crisis Services, this is the work that our crisis first responders are providing to not only provide that direct, immediate response, but also the training and systems needs that need to be worked and navigated and nurtured in order for it to be successful for our community members who are living with mental illness. So thank you for all you do every day here at Crisis Services. So next, we're going to kind of shift now to a little bit of a round robin discussion, no pun intended, as I'm handing it over to Robyn Wiktorski-Reynolds, but just to talk a little bit about what we know are some questions that we regularly get from the community to help clarify our role and responsibilities. And also, I know some comments are coming in from our viewers who are watching live with us, so we'll be addressing those as well. So Robyn, I'm going to hand it over to you.
Great, thanks, Jessica. And thank you everyone for joining us today. We're really excited to be here, and I'm so proud to sit on this screen with my colleagues here. So we are definitely hearing from the community a perception that Crisis Services brings police on every mental health call or most calls. So Tracie, I'm hoping, can you speak a little bit to this perception that may be out there?
I would love to speak to this. This is probably, in terms of misperceptions, this is probably second only to the misperception that mobile takes everyone to the hospital that we see. So this is probably the second biggest misperception in the program, is that we bring police on every single call that we go to or involve them or send them all the time. It really is very far from the truth. Police accompany mobile outreach in terms of the actual assessments in the community less than half of the time. The other half of those assessments are managed completely solely by social workers and mental health counselors on our teams that are going out into the community. We're pulling in law enforcement purely for safety reasons. So if we know that there are weapons in the home, if we know the last time we were out at the house, the person became very agitated and dangerous with one of our staff, of course, we have to have somebody along that can assure some safety. If we have serious concerns about somebody that maybe they are an abscond risk, that maybe they're suicidal and we are concerned that they are going to leave the scene when we show up, we can't take that risk with someone who is suicidal and we cannot stop the person. So there are particular situations, like I mentioned earlier, we have to take these cases case by case and decide whether law enforcement is going to accompany, but it is only a fraction of the cases that we're responding to. And when you start to add in all of the other work that comes into the program, so those additional requests that maybe don't even turn into us opening a case, you start to add those up, another 50 to 100 a month, all of those are managed separate from law enforcement. So the percentage of times where we have to pull in law enforcement really starts to dip quite low in terms of when you start to look at the overall volume within the mobile program. And then even on top of that, the overall volume coming into the agency when you factor in the hotline as well too, who calls for police a minute amount of the time compared to the caseload coming in there. So again, just, you know, if there is a history of violence, if there is an imminent situation occurring right now where we have an overdose in progress, or we have somebody immediately threatening a family member, those types of things we do need to pull in law enforcement. It doesn't mean that we won't still be responding or assisting with the response, but we do need to get a quick response, and it needs to be from law enforcement. So really, we want to reinforce our role as helpers in the community and connecting clients again to the mental health system, and trying to divert away from law enforcement whenever we can, and other higher levels of care.
Thank you, Tracie. Sometimes we hear from loved ones of those that are struggling with addiction or co-occurring disorders that we were not able to get their loved one to a treatment facility or other type of care in the same way that we are able to with someone in a mental health crisis. So can you talk a little bit about the difference with these types of presentations and the mental hygiene law that sets the parameters for that?
I can. These are really tough ones because we do get called for situations that really are their addictions issues and very serious ones often. The New York State Mental Hygiene Law, Section 945, that our staff have authority under, is related to mental health symptomology. It doesn't mean that somebody can't be using and abusing substances when along with their mental illness, because we know that substance abuse is a mental illness. but to be able to, we have no ability under Section 945 of the New York State Mental Hygiene Law to force someone into addictions treatment. That remains a voluntary process for somebody to participate in. And so we can help and make referrals, we can talk to people, we can try to redirect to the appropriate services. But under that law allows and requires a transport to a psychiatric emergency room. It does not allow for a transport to treatment for addictions issues, unfortunately.
Thank you for that clarifying answer, because I know that's something that people ask us a lot daily. It's coming up, now, and it's so important for loved ones to understand that we're not wanting to help. It's just there's only so far that we can go in terms of that system. Another question we've been hearing a lot about is, a discussion around the use of social workers in police departments, given everything that's going on. So most recently, people are asking us about a contract between Buffalo Police Department and Endeavor Health Services, and are curious what our, we can clarify what our services are and what is being proposed at Buffalo Police Department. And I think when we heard Jackie talk a little bit about the Crisis Case Manager program, really that was the basis for a lot of this work in our community, to really partner on that next level with law enforcement to do continued follow-up on those people who are consistently seeking those requests. And so what we know, what distinguishes, our services really is our 24-hour, 7-day-a-week nature of our response, and always having at the ready those designees, the 945 designees that you've heard Tracie and my colleagues speak about, that really allow that opportunity for the assessment and determination if that individual does need to go to the hospital. So, in our work, we try to streamline communication and efficiencies as much as possible to get people as quickly to the level of care that they need. And so we really are calling upon individuals to reach out to us to kind of get right to it. And we can quickly make that determination if that transport is going to be needed. And in many circumstances, where there's no transport needed, they're able to successfully link back with a practitioner or to successfully remain safely in the home. And in those cases where there is a transport, upwards of 80%, maybe more, Tracie, you may have to check me on that, are actually admitted to CPEP, meaning the clinical calls that our teams are making are accurate and in line with the clinical assessment of those over at CPEP and ECMC. Additionally, it's very important, and we're very proud of our 50+ year expertise and history in crisis work and collaboration with those. And we really look forward to working with not only Buffalo Police and all the other police departments we currently work with, but the other service providers in the community who we know want to also be part of the solution to helping people. And so our call to action is really around an integrated response, really being aware of the services that exist, not duplicating. And that's a lot of our language and communications we've been putting out to the community is look at the experts that we have in our community, what systems currently exist, how can we not duplicate, not spend a ton more money on things that we already have, but maybe enhance some of the services that already exist. So hopefully that helps a little bit. And I don't know if you guys have any other comment to that. Okay, moving along. So the next thing that we've been asking is, crisis services, we're kind of known for evolving and things are kind of happen quickly. That's how we roll. But given the urgency of the matters at hand, what's next for crisis services? What are we doing? What's on deck?
I can start that off a little bit. We hear what the community is demanding, and they're demanding less police and mental health interactions. And we support the police, but we also fully support diverting dollars towards services that reach clients before an unnecessary police intervention. So, we've been looking for ways to do this over the course of time. We've been the leader in diversionary work for decades in this community. Like I mentioned before, mobile outreach, we are in our 40th year of service, and our goal is hospital diversion. We want to divert from the hospital. We want to divert from higher levels of care. We want to divert into the right system. So away from law enforcement and into mental health. A mental health crisis deserves a mental health professional responding to it. We're really excited right now to be working on a project for 911 dispatch diversion. This is being supported right now. A pilot project is being supported by the Patrick P. Lee Foundation. And we are currently in planning with Central Police Services around this. And what this model will do, it really is diversion at its finest. It's catching these calls and routing them from the time they hit dispatch and routing them right over into our hotline at that point, and allowing mental health professionals then to deal with these. So the dispatchers will be trained to be able to identify those calls. They already receive excellent training in terms of CIT dispatch training, but additional training in how to identify those calls, the appropriate ones. And instead of sending a patrol car out, let's push those over to a mental health professional to be able to triage and to support. And maybe that call ends in our hotline. Maybe it gets pushed over to mobile for a mental health professional to be going out onto the scene. So we're really excited about being able to pull some of these calls really upstream before a patrol car even gets dispatched, and release the police to be doing the work that police need to be doing.
Thanks, Tracie. We have some questions from the community that we are going to start to tackle. So before I do that, I just want to check in with my colleagues. Jess, if there's any other comments to be made before we switch to that portion of the program.
No, we can go right to the comments.
Perfect. So I'm going to toggle a little bit here. So our first question, hold on here, is if we could talk a little bit about how we cannot involuntarily hospitalize someone who is schizophrenic and commanded by voices to do drugs and not eat at times. Is it that black and white that they must tell you they want to hurt themselves? So I think this person is trying to get a sense of, they know what an individual is confronting, but how and what they say to whoever they're speaking to, whether that's law enforcement, the doctors at CPAP, or us, what would get an involuntary transport?
Sure, I can take that. That's a really, really good question. Individuals does not have to tell a mobile outreach counselor directly that I'm going to kill myself, or I'm going to kill somebody else, or we don't need it that direct. So the law for police officers is a little bit different. They are operating under section 9.41 of the New York State Mental Hygiene Law. They need to see a lot more direct and imminent threats of harm or behavior to suggest that the crisis is imminent. Our counselors, because they are mental health professionals, can take other things into account. They can take history into account. They can take reports from certain people into an account. They're looking at judgment and insight and a lot of other things to put together a larger clinical picture, because again, it's a mental health professional responding, and be able to put that picture together and be able to make a sound decision. So in a case like that, we would be assessing, it wouldn't just be based on those simple reports. We'd be asking a lot of other questions and pulling in a lot of history and other reports to be able to decide what to do for that person.
Thanks, Tracie. The next question, is there a mobile outreach team in crisis services, or does crisis services call the police when someone is in a mental health crisis?
Are we meaning, is the question suggesting, do we actually have teams that are going right out directly?
That's how I would interpret this.
Yeah.
That's how I would interpret this.
We have lots of teams that are going out directly. So at any given point, we have a team of the frontline people. I believe it's around 22 individuals, and they operate on a 24/7 capacity. So at any given point, up until 9 to 11, depending on the day of the week, there are people stationed either within crisis services or remotely out into the field, and they're responding in a remote capacity out to these situations. And this goes on day in and day out, hour in and hour out. Right now, there's probably multiple teams out in the community providing these assessments out in the community. Again, police would only be pulled in an emergency type situation or to assist us with safety concerns.
Thanks, Tracie. Here was kind of a nice recommendation, and this individual is wondering if we would consider crisis training for clergy and faith leaders, as they're often first contact for folks when they are symptomatic. And I thought that was an interesting comment, and not sure if anyone, Jess or Tracie, you want to talk a little bit about the types of people who we have trained or who have sought training from us, whether it may not be CIT per se, but what sorts of folks we have worked with in the past.
I can start that, Trace. I think I think that's such a great comment, because really addressing mental health is a community effort. and being aware of the signs, the symptoms, things that are risks, and also when to call in to an organization like Crisis Services. I think the more we can educate everyone on that, it'll help to really streamline the response in the best interest of the person in crisis. I think clergy play a huge role. We know that they have many of their community members coming to them for various issues, and even though we're talking specifically about emergency mental health issues, suicide prevention, which is part of that, we also, as a crisis center, provide various services around domestic violence, sexual violence, trauma response services. So there's a role we can play when others in the community are presented with concerns from friends, family, loved ones, or community members. And I think when we talk about training, there's a couple different things that could be considered. Obviously, the CIT training is really targeted towards law enforcement, and now looking at 911 dispatch and kind of that part of the emergency response system. But there's many training programs here in the community that are available, and we'll be happy to connect whomever is asking this question to maybe some of the agencies that are doing trainings. For example, there's a training called mental health first aid that is almost, is kind of like a regular first aid, but around mental health and kind of steps and signs, symptoms, warning signs to be aware of and what to do. It's a great curriculum and very thorough, and really helps to put an understanding of being in the shoes of an individual in a mental health crisis and how to best approach them and work with them in that moment. So that's a great training that we can offer to connect people to. As part of our work as Crisis Services, we were founded on suicide prevention and emergency mental health. And so we do regular trainings just targeting suicide prevention and awareness. So we offer a couple different now remote trainings that are available in partnership with our Suicide Prevention Coalition that is part of our organization to train people, again, about warning signs, what to look for. We really want to encourage this conversation, and that you don't have to become the expert. It's just that if you're starting to see something concerning, that you know what to do. And what to do is to call us 834-3131 and let us help you determine what the best next step is for that individual that you're interfacing with, that you might have concerns about. So there are some other different types of training programs that we could connect various disciplines to. We've been doing some training with our healthcare system, and also just bringing awareness to mental health and suicide prevention for various disciplines who are dealing with a lot right now. Healthcare is obviously, our healthcare workers during this pandemic has been something that the county has been kind of coming together and offering education and tips and encouragement and resources. So we're very involved with our partners who are helping to do that type of education regularly, and we'd be happy to connect anyone who might be interested in training. You could also just email us at info@crisisservices.org, and we can then navigate that email to the right next step for you if you're interested in more training and information.
Thanks, Jess. The next question is about CIT training. And this individual is asking, does CIT train specifically on how the police should respond when a client is violent or aggressive?
We go over a variety of different techniques. We go over communication, how they should approach somebody, de-escalation techniques that they should go through, and which it's kind of like steps that they should take before doing anything else. So we do go over all of that. We go over trauma-informed care and how they should, treat somebody who's had a trauma history, all the suicide prevention and assessment stuff, how to ask those questions. So our training is very focused on communication and how to take those steps and talk to people before anything else. So even with somebody who is maybe violent or threatening, those techniques should be applied.
This question, that may have been our last question. Hold on one second. Let me just double check here. As of right now, that's the last question that we have from the community. But Jess, Stuewe, I'm wondering if you could just briefly speak to the role that law enforcement plays in assistance with the training and how they are involved in that.
Sure, we have some officers that assist with training from different departments. It's usually an officer from Buffalo, Cheektowaga, Tonawanda, West Seneca. We always kind of come together to do this training. It's usually me and a law enforcement officer doing the training together. So law enforcement can get both the mental health perspective along with application from the law enforcement side. And it's a good balance of that so they can get both sides of what we're talking about, because I could be talking about a lot of mental health stuff, but the law enforcement officer can put it into terms of how it would apply to them in the field. So we work together on that.
That's great. That's great. Thanks, Jess. I'm just going to double check one more spot to see if we have any more questions. It looks like we do. Hold on one moment here. So the question is again on CIT, in what areas, it's a three-parter, in what areas do you think CIT could be improved? Do we receive feedback from community members and officers? And how often is this program evaluated?
I think Jess and I can tag team this a little bit. Can you
Sure.
go back to the first question again? What was the
You
first part
bet.
of that?
In what areas do you think CIT could be improved? And I think this is going to be, I'm not sure if this is referring to the training itself or if it's referring to crisis case management, but I think we should probably just stick with the training because I think that's likely what this individual is speaking to.
Yes, so we are always looking and evaluating what needs to change on it. And so, you know, there are points that we just realize this doesn't seem as applicable anymore, or maybe we need to shift it to something a little bit different. That seems to be kind of an emerging trend. So we do that pretty regularly. In terms of improvement, I think the biggest thing that I would say is just seeing growth in it and seeing, we've trained a lot of officers and a lot of departments have invested a lot of time to get officers trained, but to continue to see that grow. Particularly in departments that that maybe only have a few officers trained. Really, the idea is to have enough officers trained so that anytime a call goes out over dispatch, there will be that is identified as a mental health call or potentially a mental health call, that there is a CIT officer, a trained officer available. So I think making sure that all the departments are at that point is really crucial going forward.
Yeah. And, you know, this individual is also asking how often the program is evaluated. And I think it's worth noting that, you know, the training is based in a national model. You know, we received, and Tracie, you know, if you want to elaborate on this a little bit, sort of the designation from New York State on our interpretation and implementation of that training, but also that you and Jess are meeting with the core group of CIT trainers on a very regular basis to evaluate, think about what's going on, what needs to pivot. Obviously, a lot of pivoting had to happen with the pandemic, and that can't be done well unless you're coordinating well. So I don't know if you want to speak a little bit to our sort of the way that we roll out this training in the New York State context.
Yeah, we certainly don't do this in a vacuum. CIT is a national model. Myself, Jessica, we go to CIT international conferences. Like, we are pulling in best practices into these trainings and into these models. So we're not operating in a vacuum at all. And we're also bringing in recommendations, guidance from law enforcement, because we can decide there's a great way to teach something. And like Jessica said, if it doesn't apply or there's not a context for law enforcement, that's not helpful. So to be able to do that is really important. And as Robyn mentioned, our model is a little bit different. Like, how we train is a little bit different than other areas across the country. I've been exposed to lots of different cities and how they do this. And a lot of times it's a one-person show that travels around the state and just delivers a week-long curriculum that's not necessarily catered to the local community and the local community's needs and climate at the time. And so, you know, we did that a little bit differently, and I'm pretty proud of that. And that's something I would not change. I do feel like it needs to be a locally driven model within cities. And so I'm happy that we go in that direction.
Yeah, we train a couple different groups of law enforcement at a time, so we can train all of Erie County. And as the training goes on, I get feedback from different departments and kind of what they do, and we incorporate that in the training as well. So we're constantly being updated, and I have so many versions of those PowerPoints because it just gets updated all the time.
And if I could just add to that, you know, another piece of crisis services, and I think this is also, I'm hoping people are getting kind of more awareness about the many layers of how our agency is actually developed, and not only the direct service side, but the systems work, the training work. We're a very comprehensive crisis center. And one of the things that has been a partner in this whole conversation is also a group that we've been managing for many decades as well, which is the Police Mental Health Coordination Project with Tracie chairs, that brings together on a regular basis the emergency response groups. So police, the hospitals, emergency ambulance services, other mental health providers, peer specialist agencies, and crisis services, to really kind of talk regularly as stakeholders in the emergency response for mental health on a regular basis. And really the CIT piece really came from that collaborative discussion about, let's do this. We need to do this as a community, and have been working diligently to get this as a universal, really, expectation across all police jurisdictions in our community. And I think it's important to note that there are several police jurisdictions. So it's not just like you're training one entity. There's, I think, up to 22 maybe, or, you know, different police jurisdictions that are part of needing to be trained. So this stakeholder group, I think, is a critical piece too when you're talking about evaluation, because also part of that process is a quality assurance aspect where people can bring together, you know, situations that they want to review, both the pros and the cons. You know, we need to also highlight what works well and how do we implement that more, and how do we learn from that more, and really build on the strengths, but also to really evaluate, was there any discrepancies or gaps in the system that or trends that are occurring that we need to, you know, address and kind of adjust to make sure that it helps to improve that emergency response. I mean, time is of the essence in the work that we do, so it is critical that the processes are really evaluated on a regular basis. But that's another layer to our organization, is the coordination of that community stakeholder group, the Police Mental Health Coordination Project, that really feeds into the work of crisis services and our mobile work, but also the CIT program and just the communication overall amongst the mental health providers in Erie County.
We have one final question. Thank you all for that. One final question. Someone is just wondering if we could elaborate a little bit more about the pilot program around 911 dispatch diversion. No, Trace?
So my mute button, of course. Yeah, you know, this is not a new concept. This is something that exists in a lot of cities. Again, you know, attending a lot of conferences, you learn about these different models. Most close to us would be, I believe, Broome County, New York, has a similar model where it just, as those calls are going into dispatch, that dispatcher is trained to be able to identify, is this potentially a mental health issue as opposed to a police issue? And if it is a mental health issue and it's someone just needing to talk to someone or needing a mental health professional, the logic is, why are we sending a patrol car out onto the scene at that point? That patrol car may very well get mental health involved in a lot of situations, and some they may not. But either way, right from the start, if they can identify that this is more of a mental health issue than it is a police issue, why not get that person over to a mental health professional? So being able to immediately do a warm transfer of that call, and our system will be set up to be able to accept that warm transfer, talk to the dispatcher, and then put that caller through to our hotline counselor, directly to a mental health professional who can better assess the situation and what the actual needs are. Again, in lieu of sending a patrol car out. They're already overburdened with the work that they do. This is work that should remain within the mental health system.
So I just want to reiterate too with that is that this hasn't started yet. So we definitely don't want people thinking like this is happening right now. We literally we're in active discussions with the appropriate stakeholders on where this is going to be launched and how this is going to work. And the purpose of a pilot is to gather data, to smooth out operations, and to ensure that things are working properly. And then, we like to talk about scaling up. So once we have everything we need and secure the resources to make this happen, then we are able to launch. And so we really want to encourage those of you that are watching to, reach out to your local legislators and, speak to support for this, because, this is a need in our community. As Tracie had said, it's best practice in many communities across the country with incredible success rates, and is more cost effective from sort of a prevention side of things than sending out a higher level of care or law enforcement response when it's not needed. So we would really encourage your support and us seeking support to launch and sustain something that really is a game changer for a system, and actually a pretty easy fix, a pretty simple thing to implement, to make a big difference in people's lives. So I'm just going to do one more check. I believe, yep, that is all that we have for questions from the community.
Great. Well, I just want to reiterate, I think, as a community and kind of just obviously nationally, the attention around the needs for not only individuals with mental illness, but also the role of law enforcement is something that we're monitoring and we're a part of, and we're discussing regularly here at Crisis Services, because we are an emergency provider. We are crisis first responders. We do have interface with law enforcement on a regular basis, and it's our role to help really shape and nurture the system to make sure that people are connected to the right level of care as well as the right system of care. And that, I think, is what has, I hope, shined through this discussion today with the different pieces that Crisis Services manages, not only through our 24-hour hotline, who, our hotline counselors are available for questions and guidance and will help you navigate what the best right next step is, but also the different amazing professionals that are doing this work day in and day out. And I think that's something I just need to highlight, is that we are crisis intervention experts, and we want to make sure that as a community, that we're using the expertise of our organization to really help assure a process that's successful and sustainable when we're looking at different reform efforts and different initiatives here in our community. But I do want to really thank all of our partners, that really help in this day in and day out, as you've seen, not only with our teams who are in the field, with our ambulance providers and other emergency service providers, including law enforcement, but the training partnerships as well as the case management services. This is all done together in a collaborative manner. And I think the more we can really understand that collaboration is key, but also that we can continue to work towards the goal of really assuring reduction of police involvement in behavioral health needs. This is just a system shift we have to work on. We are very conditioned to call 911 in emergencies, but we need to really look at when it's a mental health emergency, where should that go, and how can we help to navigate the system to better provide care and choice for those that are in need of help during a mental health crisis. So I want to thank my team here, amazing women who are doing really just powerhouse work every day. I can't, doing this work and running a 24-hour agency and this leadership here, it's not easy, and it's critical. So their expertise, their dedication, their passion and commitment is why we are able to do what we do every day. So I just want to thank you all for everything you do. I'm very honored to be on this group with you. But I also want to really let our community know that we're seeing what's going on. We want to be a part of helping find the right solutions. But those solutions are building on existing integrated services. We need to enhance, we need to improve, and we need to evaluate. And we're committed to doing that on behalf of crisis services and our community. So as people watch this later on, if there's comments that you have or questions you have, please don't hesitate to continue to put those into the chat or the comment section of the post, because we want to hear what questions you might still have after today's programming, so we can make sure that we're doing those educational moments to really help eliminate a lot of the confusion that's going on right now, but also really build the champions in all of you to make sure that we're directing people to the right level of care, and also being champions on behalf of crisis services to get our number out, 834-3131, 24 hours a day. Call us, let us help you navigate what that best next step will be for somebody in crisis. So again, thank you, Tracie, Jessica, Jackie, Robyn, for this amazing discussion today. And we look forward to continuing to share our expertise, our resources, and our commitment to the change that we know is needed for our community. So thanks again for joining us. Have a wonderful day.